Happy Friday, everybody. We are back. Fridays at RP. New episode. I believe this is the first episode of 2021. Hope everybody is having a good 2021 so far. I hope you have left 2020 behind. You have learned something. You're moving forward. I know we have here personally and in the business, but this is actually day 3 of our series of injections this week. We had procedure on Wednesday, Thursday. We got 2 adipose stem cell procedures today, and then tomorrow we have perineural treatment for some headaches, and then nerve hydrodissection for some low back and some pudendal neuropathy. So we're excited to get going here. I hope you guys enjoy this week's episode. Let's get to it. Gorgeous morning out here. Here we go.
Let's put our living stereo stylus in this groove.
Hey everybody, so we finished up. Today's Thursday, but obviously this is our Fridays at RP, but we have been so crazy busy here that we actually had procedures Wednesday, we have today's Thursday, and we got tomorrow Friday, and then we actually have 2 on Saturday, which is really awesome, helping out a whole bunch of people. I didn't have a chance yesterday to film, but yesterday and you may have seen on different platforms and things like that we have had a patient who unfortunately had a complication from a knee surgery that he had. The patient went in for a scope and basically a cleanup. Doc was looking in there to see if there was any loose bodies and things like that. He trimmed a few things, cleaned a few things up, nothing major with a meniscus or anything like that. The patient then had some bone marrow put in there as well. But unfortunately, 6 days or so after the procedure, the patient started having some really significant pain, a lot of restrictions in range of motion, and some significant swelling around the knee. And so this was, I think, about 2.5 weeks ago or so. And so we did a joint aspiration and found that he was bleeding into the knee joint, and that's called a hemarthrosis. And so we have since then drained his knee 3 times. Yesterday, so Wednesday this week, was the 3rd time that we drained it. Each time there has been, it's been bloody. The first time was our typical hemarthrosis, dark red blood, which is predominantly blood. We got about 25 cc's or so. And then our second and third time, not as bloody, but definitely still bloody. And you'll see, Mark will put in some pictures here of that so you can see what that looks like. But this patient is unfortunately in a significant amount of pain because of this, because having blood inside the knee joint like this continually is not pleasurable, because the iron content that's in the blood is really, really inflammatory. And so we are hoping that we are able to get that to stop bleeding. And one of the ways we're trying to do that is with some high concentration dextrose. Our next step, if that doesn't work, is we are going to go and put PRP into the knee joint, hope that those platelets help to clot off whatever is still bleeding in there. And unfortunately, he's just kind of suffering right now, which is unfortunate, but hoping that we can help that out. And then our procedure that we did today. So patient has had long-standing history of low back pain that is now kind of radiated up into some thoracic pain, a little bit of cervical pain, and then some flank pain. He has had many rounds of regenerative injections in the past, 2 or 3 prolotherapy treatments, and about 4 or 5 PRP treatments from different providers, but hasn't really seen a huge ton of relief. And so one of the things that came up on our physical exam was that there was some neurogenic inflammation, or inflammation coming from the peripheral cutaneous nerves. In his case, the medial branches off the dorsal rami, a little bit on the lateral branches off the dorsal rami, and then the superior and middle cluneal nerves on the one side. In talking with him, the treatments that he's had in the past have all been focused on the traditional things that are treated with prolotherapy and PRP, which is joints, tendons, ligaments, muscles, that type of stuff. He hasn't really had a ton of treatments for the peripheral cutaneous nerves. And so our focus today was we did a cervical, thoracic, and lumbar erector spinae plane hydrodissection. Again, we are trying to open up the space where the medial cutaneous branches are running. We are also trying to get some of that fluid a little bit closer to the dorsal root ganglion, which is where the cell bodies are for these medial and lateral cutaneous branches, to see if we can help to drop his pain. And then we also did hydrodissection of the superior and the middle cluneal nerves on his affected side, again opening up the area around those nerves so that way the nerve inflammation goes down, decreases, and hopefully he's in less pain. So excited to track his progress over time, especially because he has been through a lot, obviously with having 7 or 8 different regenerative injection procedures. And this is something I think that is important for a lot of you guys to understand, that if a treatment doesn't specifically work for you, and I'll talk about it in the regenerative injection space. So if you have a prolotherapy treatment and that treatment doesn't work for you, I believe that a lot of the times the reason it doesn't work, and I'm talking like 0% improvement, not if you get like 10, 15% improvement, because that's still a response. I mean, if you get no improvement, it usually means that the physician was incorrect on the diagnosis of your pain generators. They may be correct on the diagnosis that you have on imaging, right? You may have degenerative disc disease, or you may have facet arthropathy, or whatever it is. But if the injections are not creating any change in your pain, then it likely means that the correct structures are not being injected. And physicians choose which structures to inject based off of what they think is causing pain. So if I think your supraspinatus in the shoulder is causing you pain, and I treat your shoulder and you get not 0% better, the reason is because I was incorrect on my theory or my assumption, my choice, that the supraspinatus was what's causing your pain. And so just please think about that as you are going through your healing journey, trying to figure out what is causing you pain, why you're in pain, and what you can do about it. Is look back at these failures and understand that the failure is actually really, really important information. The failure in the regenerative injection space tells you it's not something, which is sometimes a huge, huge piece of information. I understand that it is not as satisfying as the huge piece of information of finding your pain generator and having it treated. But at the end of the day, if you have a failure, it is still important information. You just got to continue on. All right. All right, everybody, we just finished up Friday. We still have procedures tomorrow, but just finished up our procedures here on Friday. Today we had 2 adipose stem cell procedures. Both those procedures we had mixed with PRP. Also take in that new beautiful clock up there. But overall, really, really good day. Our first case, we treated the ankle, knee, hip, low back, shoulder, and then some of the thoracic spine. And this athlete has basically initially had an ankle injury that then resulted in, probably contributed to, but she ended up having a knee injury, which then threw that kinetic chain up through into the hip, and then the contralateral low back, and then that ipsilateral shoulder. Has had several issues for quite some time. And so did a lot of different things today. Put adipose inside the joints and the fat pads around the joints. We treated tendons, ligaments, supporting structures. We especially treated her patellar tendon because when she had her ACL graft, they actually took from the patellar tendon, and those two halves never fully joined back together, and so she has had problems ever since. And so we worked on those areas and putting some good stuff around that. And then our second case was a patient who has had, maybe we could link to our the Fridays at RP, Mark, maybe do a little box or something, but we treated him probably about, I think 8 weeks ago or so. We did some injections for the cervical spine. He has central stenosis and some lateral stenosis. And we did PRP for the supporting structures in the neck last time, supporting structures in the neck, and then also an erector spinae plane hydrodissection, which helps to bathe the dorsal root ganglia and some of the smaller spinal nerves as they're coming off the nerve roots. And so we did that. He saw a good response, a reduction in symptoms, and he plateaued. And so we decided to do an adipose stem cell procedure with some placental matrix, along with PRP, again, mainly for the neck. He also is actually currently having a scalp treatment where he is having some nanofat and some placental matrix injected into the scalp for some hair loss. But on my end, so what we did today was basically did the same thing as last time, which was our goal was to help with the supportive structures in the posterior cervical spine. So the facet joints, the capsule around the facet joints, the nuchal ligament, the suboccipital muscles are the four main areas that we look to treat when we are trying to help restore some integrity to the cervical spine, so that the central canal is a little bit larger, has more movement, more room for movement for the spinal cord, so that the central stenosis is not as bad. And then we also decided to do a bilateral transforaminal epidural, which is basically where we advance the needle in where the nerve root comes out of the foramen, the transverse foramen, and inject the fluid there. We injected some placental matrix predominantly and some high-dose PRP in and around that nerve root, which then some of that's going to travel into the epidural space. And we did that to try and help more with some of the neurological symptoms that he's getting, some kind of numbness, tingling, spidery feeling on the back of his neck. He did see improvement with our cervical erector spinae plane hydrodissection at the last treatment, but we decided because we were going a bit stronger this time around, we decided to go ahead and add in the transforaminal epidural. So that was Friday. We still got tomorrow, Saturday. So hope you guys are sticking around and enjoying this episode. See you soon. All right, everybody, we just finished up our last day here of the week, which is actually Saturday, for this week's episode of Fridays at RP. We had two patients today, one who had repeat perineural injections for a bit of TMJ pain and headaches that they were having along the auriculotemporal nerve path. And so very simple procedure there, just some subcutaneous dextrose to help calm down those nerves that are contributing to some of her pain and symptoms, things like that. Second case is a little bit more of an interesting case. So we have a patient who, during a movement assessment, she injured her pudendal nerve. So the pudendal nerve is a nerve that's going to innervate a little bit of the genitals, the perineal region, and kind of that inner gluteal fold area, and unfortunately can cause a lot of pelvic floor issues or pelvic floor pain for both men and women. And so this patient, in conjunction with that, had also had some the inflammation travel, and it affected her middle cluneal nerve and then the superior cluneal nerve. So Our physical exam was pretty straightforward. We palpated those areas. The nerves, we could actually feel the superior and the middle cluneal nerves. Normally you can feel them, and then when they get really inflamed, they get larger, so they're ropey. You can feel them. And that recreated some of her symptoms. And then palpation of the pudendal nerve, again, recreated some of the symptoms that she was getting into the groin region and around the medial aspect of the glute or the buttock. And so we did a hydrodissection of the cluneal nerves, the superior and the middle on the left side, and then middle on the right side, all the areas that were tender. Basically, under ultrasound guidance, we find the fascial plane that these nerves are lying in, and then we open up the fascial plane. This is going to give the nerves some space to actually be able to slide better, to basically breathe and not be compressed, which is one of the ways that nerves can be painful. And then also the PRP or the PPP, depending on which areas we are treating, those nerves, those solutions are helpful in reducing the neurogenic inflammation. And so did that. And then we also treated the pudendal nerve in 3 different areas. We treated it just off of the ischial spine, where it runs in between the sacrospinous and the sacrotuberous ligaments. That is a common area where the nerve gets frictioned because it's sandwiched between those two ligaments. And so normally it can move smoothly between those two when we need to, but if the nerve gets inflamed from an injury, then that nerve now takes up a bit more space and it might be more likely to get friction. And so we hydrodissected that plane. Then we moved down and hydrodissected the pudendal nerve in Alcock's canal, which is a fibrous membrane that is covering basically along the lesser sciatic notch region. And so we hydrodissected the pudendal nerve there. Again, another common place that, because it's traveling through a canal, if the nerve gets larger, then it is more likely to have irritation when it gets irritated, because it is filling up more of the set volume space that it has. And then the last spot that we decided to treat was a little bit more distal, kind of where the pudendal nerve is turning into the perineal nerve. And so that is going to be a little bit closer towards the ischial tuberosity, and injected those areas. The important thing with her is that we recreated a lot of the pain and different sensations that she has during the actual procedure, which is a really, really positive sign. When we do an injection and we recreate the symptoms that the patient experiences, the reason they are coming to us, it greatly, greatly increases the chances that we are going to see long-term resolution or improvement in their symptoms. Because when you have something that is irritated, pissed off, damaged, basically the brain is sensing that there's something wrong, which is a pain signal. Brain senses something wrong. When we put a fluid around it, when we put a needle near it, the brain senses very similar things, and that's how we can actually recreate the pain. And so when we are able to recreate pain with our procedures, it increases the chances that we are going to have a really, really good outcome. Not guaranteed, just in the same way that sometimes we don't recreate symptoms and patients end up having amazing, outstanding responses. So it's not a mandatory thing, but when it happens, it usually means that the patient's going to have a really, really good response. So that was our week, 4 days of procedures. I'm happy, I am grateful, I am thankful. Thank you if you made it all the way through to the end of this video watching, and we'll see you next week.